becomes infected. We want to look for signs and symptoms
This
of
is
abdominal
common
pain,
after
cramping,
childbirth.
foul-smelling discharge, and tachycardias. So this is most commonly after childbirth. Again, ripping and tearing can cause infections. It's not endometriosis, which we will talk about. This is an infection of the endometrium. So we want to transport and provide pain management if we can. Endometriosis is when you have tissue growing outside of the uterus, and it starts linking together your abdominal structures. Like it will link your bowel together. So it disperses tissue and things just start sticking together. A lot of people with endometriosis require a complete C-section because your body keeps regenerating tissue and depositing it throughout your body. So most oftentimes it's abdominal pain complaints. They go in and do a CT and has seen that your organ structures and your bowel are fused together. So they don't often see this until, because they don't have pain, until structures become worse, until they're trying to become pregnant and they can't.
Sorry, what
Yeah.
hysterectomy?
What's that?
You said C-section. Do you mean hysterectomy?
I'm sorry, I mean a C-section, yes. I'm sorry, I mean a hysterectomy. So, okay, okay, patients with endometriosis will end up, when they do become pregnant, as a C-section because of their structures sticking together, and treatment of endometriosis is a complete hysterectomy, getting rid of all of that. The other thing that endometriosis produces is really, really heavy, painful periods. And this is where they're like, I have really heavy bleeding for like 4 to 7 days, really bad cramps. Like you will see people doubled over in pain, not able to function. So also really, really severe fatigue. I think that fatigue is linked to the blood loss because when you have iron deficiencies or low iron or low blood, you become really tired. So we just transport these patients in comfort care and provide pain relief. There's nothing that we can do for this except supportive care. Same thing for those infections. Here's uterine prolapse. This is your patient that is literally holding between their legs and they say something feels like they're going to fall out. Sometimes it is all out, like the whole uterus is outside of the vaginal openings, and other times it looks like crowning to where the uterus is just slightly protruding through the vaginal opening. Again, a physician will take a gloved hand, gently push that right back through the opening, and they will treat that with hormones to provide structure again to that, and they also do slinging. They can also sling the bladder, because the bladder is the other thing that can prolapse. Yes?
Endometriosis. To me, this sounds like, when I'm reading it, it sounds like it creates
Scar tissue, and it deposits skin.
Well, to me, what it sounds here is like making a new uterus outside of the uterus.
It's generating tissue, and your body doesn't know what to do with it, so it latches on to things. It's the cells in the uterus, but it's predominantly tissue outside that just starts sticking everything together. It's weird. So you have tissue in your uterus, and your uterus sheds its wall every month, which is your period. But when it's shedding, it is also shedding tissue, and then that tissue is found outside of the uterus. Your body regenerates certain tissues. Okay, let me explain to you with my thyroid. I had my thyroid removed. Your thyroid, because I have cancer, your thyroid is one of the things that naturally regenerates. Your body, it's called T3 and T4, Dr. P talked about it. Your body still wants to regenerate and recreate that tissue. Your tissue actually regenerates in your body and your cells every 7 years. You get all new stuff, and so how often your body regenerates everything. Cells die pretty early, but your body is coded to keep reproducing those cells and that type of tissue. So even though I don't have a thyroid anymore, I will continue to be scanned for the rest of my life and have to take medications that suppress T3 and T4 so that I don't regenerate thyroid tissue. The same thing is in the uterus. Your body is programmed to recreate that tissue and that lining. And when it goes outside of used to recreating these things. And so endometriosis, the reason why their periods are so heavy is they're duplicating their effort, they're growing more tissue and it's pulling things together. It's just tissue from the uterus, outside of the uterus, sticking things together. Your body doesn't know, it's just fusing things together. It fuses organ structures together. It doesn't know that it's outside of the uterus, it just knows, hey, right there is uterine tissue, keep regenerating that. Your body's just in code reproducing. Does that make sense? Like your thyroid, it'll do that. Your body, like, it's very, very complicated down to the cellular level, which is why we give you guys Bio 160. And Dr. P will be back this semester for a couple of lectures. He does genital urinary, and he does he does our endocrine lecture for medical, because he's the one that should talk to you about insulin and your pancreas and your thyroid, because he goes like way in depth about hormone replacement stuff. So, and how hormones work and function. So yeah, that's ultimately it, is your body is just copying that code outside of where it should be. And it causes a lot of pain. Uterine prolapse, hormonal changes in the body where the bladder or the uterus will prolapse or come out of that vaginal opening. Again, it is a organ life threat to put that back in the body, and that's why anytime we have an organ structure outside of the body, like an evisceration where you have bowel, what kind of dressing do we cover it with? Moist, sterile dressing to try to keep that tissue moistened so that we don't have tissue necrosis or death. Same thing with that uterus. We don't get the luxury of punching that thing back in there. We cover it with a moist, sterile dressing, and we take them to the hospital. A provider has to be the one to do that. Lucky doctors. Doctors can do so much cool stuff.
Sounds like paramedics.
It's not. So it's weakened because of decreased estrogen in the body. I will tell you, people that have more adipose tissue who are heavier carry a lot of estrogen. The problem with carrying adipose tissue and extra estrogen, if we don't have enough, our organs fall out. If we have too much, it's linked to cancer. Estrogen is a cellular change. It causes cellular changes, and it is linked to high estrogen levels to certain types of cancers. Again, cells are amazing. They're pretty cool. Patients often report before that uterus falls out a heaviness or a bowling ball. I've had someone say, it feels like I have a bowling ball, like pressure, like pushing down there. Same thing with a bladder, is that it's just heavy and it's full and it's gravity, right? So when they stand up, it gets worse. All of these patients walk. These are patients you sit on the gurney and you kind of move them. They can also feel fatigued and low back pain. And it's worsened by prolonged standing. Yeah.
So it's spontaneous how it happens?
Yeah. Yeah. It's pretty quick. Like they go from having like back pressure to heaviness to it's coming out, right? Gravity is path of least resistance. And uteruses and bladders are heavy because they hold blood, tissue, and then the other one's urine and tissue. So bladders and uteruses can be heavy. They also call them boggy. Like you'll hear that term boggy when someone has postpartum hemorrhaging, to where it's just soft and it's uteruses are supposed to contract, and so are bladders to get them to stop bleeding. So you'll feel boggy, just like big, mushy, boggy, bloody tissue. Yeah.
So like in EMT school, they tell us when a woman's in active labor, they tell us to like kind of angle them up so gravity can kind of help push, keep the baby from going all the way out. Do you do the same thing with this at all?
No, so you mean like breech presentation, you lift the pelvis up to keep the baby from delivering?
Yeah.
I don't think that's a bad thought process. I think that's a really good thought process, but ultimately if you already feel it at the external genitals, it's already fallen. Your uterus is like right below your belly button. So everyone point to your belly button. If you make a fist just below that on your female patients, like that's about as low as where your uterus is. And they will measure that measurement from your belly button to the bottom of your pelvis, your pelvic wall, where your seatbelt should sit under your belly. Like that is called fundal height when they measure that, and we'll go over that more in OB. But yeah, that's right where your uterus sits, is right below your belly button. Okay, again, don't replace the tissue, cover it with a moist, sterile dressing, Same thing with an evisceration. Anytime we have tissue outside of the body, we have to keep it moist to keep it alive. And we want to use saline if we have it. Sterile saline is the best. It's just the best fluid that we have that we can use. Anytime we have vaginal bleeding, we've already talked about this. There are reasons why females bleed. The most predominant is your period.
Menses.
If it is bleeding more than 21 days, there is a deficiency. So the whole time period is 28 days. This is saying if it's more than, they're bleeding more than 21 days, that means they're bleeding 8 more days a month. So watch this. Check for conditions of underlying disease or like instability of the structure that cause more hemorrhaging. Uterine fibroids cause bleeding. It's called a fibroid. It looks like a big stretch mark on the uterus, and it's instability. Those cause irregular bleeding. So just ask your patient, what's normal bleeding for you? What's normal period look like? And is this normal? And what kind of bleeding do you have? There's bright red blood, there's dark blood, there's particulates in tissue, so just ask what they have going on. And again, just put them on a pad, transport them to the hospital so the physicians can see how much blood loss has occurred. The thing that we're worried about is extreme blood loss or sanguination. That means you're bleeding out of your body, like you're running out of blood loss. So keep that in mind. When you have dysfunctional uterine bleeding, it's because you either are too heavy, you're over 40 because of hormone changes, high stress. How many of us have high stress? We're EMS providers and we're all in medic school. We all have high stress. So guys, you're lucky. Gals, sorry we're putting you at risk. You also can have polycystic ovarian disease, long-term medication use like contraceptives and excessive exercise. So, and uterine fibroids, again, look up the stretch mark. Have your patients follow up, OBGYN, here's the treatment, hormone therapy, and we just give supportive care to the hospital. Other things to consider. The big thing in trauma is going to be blunt force trauma caused by objects or pelvic fractures. We have that little mannequin guy in here, our skeleton. Okay.
His head.
No. Alright, so everyone hold your hands like this,
Like what?
your pelvis. You have 2 small rings at the bottom of your pelvis and an open book pelvic fracture. In these rings live your 2 what arteries that go through here? Your 2 femoral arteries. And when you have an open book pelvic fracture, everyone go like this. The bottom rings of your pelvis break. So your pelvis itself has 40% of your blood volume circulating through it, and you have those 2 what circulating through it? Arteries, your femoral arteries, perfect. So this is why in trauma we inspect genitals, because you have a high, if you break that pelvis, like people who are ejected or have hard impact style injuries like thrown, that is where you have that high potentiation to bleed, right? So external genitals. In female patients, it'll just start pouring out. In male patients, you're gonna see scrotal changes. You're gonna see increased size and bruising over time. So that's why we check the genitals in trauma. For
Jenny,
open
when
book
you-
pelvic fractures.
When you said it was pouring out, it's gonna just come out of the
Path of least resistance
Okay.
and your body weight, it's just gonna start trickling out.
Okay.
Like it's a slow, steady stream. It's not arterial. It's not gonna start shooting out. It's just gonna start pouring out because it's path of least resistance.
Okay. Okay.
Yeah.
Can you determine an open book based off of just shortening and rotation?
So that's upper pelvis where your femur sits in the upper pelvic girdle.
Okay.
So lateral shortening and rotation is upper where your hip meets the top of that pelvic crest.
Okay.
The bottom part where your arteries are. So again, open pelvic book fracture is what it's called. Again, pelvises hold a lot of blood already, but then we have the arteries that go through there. And that's where we'll see the external bleeding. The other thing is a direct blow to the peritoneum. So this is people, I don't know why they ride bikes without seats, or ride on a bike and hit that metal bar, jungle gyms where girls are climbing on equipment, climbing on strings,
Yeah.
horse riding, but
Me and this girl
the
playing and she
most
fell.
awful
Yeah.
traumas I've seen are like hitting metal structures
Yeah.
from playground equipment. So pretty bad stuff. Foreign objects, and then we have abortion attempts. It is on there, it's in the book, but yes, it does cause vaginal bleeding. So complications, they need to be corrected and treated urgently and emergently, taken to a level 1 trauma facility or an OB capable hospital, and we want to be ready to treat for shock. Again, by the time we see it, it's already been bleeding for a little while. Ectopic pregnancy, we've already chatted about earlier today. It is a fertilized ovum in the fallopian tubes. It is not a viable birth, nor can it be reimplanted. It just doesn't work. That blows my mind, because they can create life in a tube in a lab, they just can't reimplant a fertilized ovum. So, pretty wild. Ectopic pregnancy, the big one is PID, but previous ectopic pregnancies is a risk factor, tubal ligation, because when you're tying those tubes, it throws tissue, and previous surgical adhesions. Like adhesions are where things have healed from surgery. So C-sections. Talked about this pretty heavily. Management is treat your patient like you would anyone that you don't want to walk. You want to give pain management. IV therapy, they could lose blood, so treat them like a trauma patient. 2 large 4 IVs, 1 for fluid, 1 for blood if they need it. They don't necessarily need 2 flowing IVs, but start 2 18s in this patient, because 1 could just be fluid and 1 could be blood products when they get to the hospital. These patients, they will type and screen almost immediately. Who knows what that means? Getting a type and screen.
Get their blood
They
type
will
and screen.
draw their blood and get their blood type, because they will most likely use or need a transfusion. There are cultural things and religions out there that do not allow blood transfusions.
Jehovah's
So we have
Witness.
to respect that, right?
Jehovah's
So
Witnesses.
one is, you can have a patient that their faith is Seventh-day Adventist, they're not allowed to take blood products,
Them too.
even in the
I know.
event of trauma. Pretty wild. There's also cultural practices that
think-
don't
I think
allow
she
that.
meant
So they will
What did she say?
eventually
She said
regain enough
Seventh-day
blood,
Adventist.
but blood takes a long time for your body to produce after you've lost a lot of blood. So it may or may not make it. We need blood to circulate oxygen to our tissue in our body, so it is really important. So keep that in mind. If you have a patient that says, I don't do blood products, that you can't give those to me, we have to treat for shock, and that's basically the only treatment option that we have. And we have to let the hospital know, right? If they disclose that to us and they become unconscious, unresponsive, it is our duty
Yeah, but
to report and to have that continuum of patient care that the patient stated this is what they.
Yeah, but you might as well have a DNR.
Yeah.
What if
That's
the
the
patient
case.
is unresponsive on scene and family notifies us of that religious belief?
You have to let the hospital know, and ultimately it's up to the physician to contact the family, but they have to honor cultural and religious practices. There
For
are
our
things, huh?
So for our care, for patients,
Oh,
you
yeah,
know, like
but
you
the other
said, patients like
question.
unconscious, but family on scene, like, does
We
it
can
work like a
just, we can
DNR?
just
You're
start
supposed to work
IVs,
up
we can start
like
fluids,
a code
we can
until
start
you get the DNR,
pressers,
right?
if we have that
Yeah,
ability
but
to
you can
start
have a DNR
pressers,
and specifically state that you don't want blood products, but you can have
keep in mind,
everything
if you
else.
have someone bleeding
You know
and
what I
you're
mean?
doing
Yeah.
pressers,
So why
you're
don't you
gonna
just have
cause
the
them to
paperwork
bleed
begin with?
faster than the rest of the blood volume that they have.
So you're
So
saying
they'll
like if
do
you get
a
a
little bit
patient
of that in the
and you
hospital,
need to give them
we don't do
blood,
that unless it's
Yeah.
Just
critical
give them
care, and
the
it's
blood.
usually not in terms
Is that
of
what you're saying?
bleeding.
Yeah, if you don't
It's
know,
in terms of
unless
just
it's document,
Yeah, what's your question, Kate?
unless it's documented, it doesn't make any sense to me, because then it's just verbatim, it's just,
Yeah.
he's,
We just don't.
Gabrielle?
yeah, I just, like, I know the family could tell us or whatever, like, I just feel like documentation, like, I get it, you can have a DNR and you can say, hey, I want everything else, I just don't want the blood.
So ultimately, if I have a DNR, like I signed a DNR,
Mm-hmm.
and my children are like, you have to work my mom, 9 times out of 10, they will work me because it was my children's wishes. They
Okay.
have to be willing to respect and honor my wishes. Just like a DNR is not necessarily a do not innovate. So DNI
Yeah.
and DNR are
Yeah.
two very different things.
Yeah.
So like let's say I have end stage cancer,
Mhm.
right? And I have a DNR. But my kids just don't want to let me go and they want me to continue to be worked and have treatment, and I'm not conscious enough and alert enough. A physician has to be willing to take my DNR over my family's
Really?
wishes.
Is that
Yes.
here? This is here.
Mhm.
Okay,
So,
because
if-
back in California, it's not
So
like
if you
that.
were to die and your kids
If
right
it
now are
says it, it
like,
says it.
I
Work
want you
my
to
mom,
work.
even though I have a DNR with me and on my chest, you would have to start working me and contact medical control
Mhm.
and say she has a DNR, it is signed with her picture on it on the orange form, and her kids are adamant that we work her, what would you like us to do? Your doc is most likely gonna say, work it, bring her into the hospital. Yeah.
I'd be pissed.
I know.
I
I
would
would
be
be
pissed too.
pretty upset too.
I would be pissed
I
too,
agree.
but this is where it's important, like, we need to have these
That's-
conversations and express our wishes to our loved ones about
Yeah,
what we
well,
want to
That's
have.
where
Things
in
get
somebody
the
hairy
in the
carry
hospital
when-
needs to
sorry.
advocate for that patient.
You know what the doctor did when they brought in a trauma, actually difficulty breathing,
It's a legal document
and he
that
was
your
talking to
next
the
of
family,
kin
and he's
has
like, "Hey, look, like she's gonna be on the bed for who knows how long. She'll probably never come off of it, and she'll probably
I thought
pass
power
on
of
it."
attorney can only be,
And so the family agreed that they weren't gonna do that, and they were just gonna let her.
That's not necessarily true, like, when you go in for a
She's ready to
surgical
go
procedure, you
in
can
the next
appoint a
person.
power of attorney and sign a document
Yeah.
right then and there on every
And
hospital
he like
stay or
literally verbal,
admission.
verbal
Like you assign a next of
right,
kin
tell
or a
the
power of
family,
attorney.
yeah, like
These are
literally
the
explain,
only
like
things in my
over-explain.
EMS career that have been tricky, and this is where you contact medical control every time and you put it on the doc. Because I don't want to be sued by the family for not working this patient. I would rather put it off on the doc and say, per Dr. Roberts at Florence Hospital Anthem, we are not working this patient due to having a DNR, time of death, blah, blah, blah. Like, always put that on your base hospital and your medical directors, because these are the things that you will be called into court for. Same thing with, blood product administration. If you have somebody that's internally hemorrhaging and bleeding, they're gonna need blood products. There are agencies right now that carry blood, Arivac is carrying blood at certain bases, super cool. Blood product, guys, blood product is
Yeah.
really temperamental, it has to be kept at a certain temperature, and there's a lot of contraindications to giving blood. Your body can have an allergic type reaction to blood product, so it's pretty risky, but Arivac is doing it right now, and that's why a lot of people just get the regular, was it O negative, the universal donor for everyone, but they will do type and screen, because they do like to give you your type of blood when you go to the hospital in this event. They always hold whole blood when you go to surgery, every time, so. Put our patient on the cardiac monitor and transport. We need to, notify the hospital, again, OB center with a gynecological surgical intervention or a level 1 trauma facility for surgery. Let them know what we've got. There's a very good chance that they'll just say, go to the upstairs or report to labor and delivery. Sometimes they'll take them in the OR, but if they suspect that, and if, you know, if it's an ectopic pregnancy, they'll take them in the OR, for an intake area. If your patient is pregnant, experiencing bleeding complications, you're just gonna go straight to labor and delivery. So, again, pregnant patient, that she knows she's pregnant and you see a big belly, you wanna go to labor and delivery with that patient every time for every complaint. After 21 weeks, we go to L&D for everything. If it's an ectopic pregnancy, that's a regular ER admission. Is that good with everyone? We're all good with that? The other thing that I want you guys to think of is if we have vaginal bleeding with a pregnant patient and the baby's not term or due, we need to think of a higher level NICU. So how many weeks is viability?
20.
20 to 21 weeks is viable pregnancy. And what's the last thing to develop in utero?
Your lungs.
The lungs. That's why we have to consider NICU, right? So if mom's involved in a car accident and she's pregnant and she's having vaginal bleeding, you wanna think high level NICU. Who is here today? Who visited us today?
Banner Desert.
Banner
Desert.
Desert. What did
Yeah.
she say about their NICU?
They have a level 3.
Their they're the highest in the state, level 3 NICU. So does Chandler Regional. So Banner Desert and Chandler Regional are the highest in the state for NICU. You wanna transport your high-risk mamas there. Because you know what's gonna happen if you take them to Mercy Gilbert? They're gonna deliver and they're gonna ship baby in the baked potato babies or little tiny babies in those
Incubator
incubators,
bags.
and they're gonna fly them to that next hospital and leave mom there to recover. So just if you suspect mom's pregnant, she's bleeding, think high level NICU, get that kid where they need to go because they don't have their lungs developed yet, and they're most likely gonna have respiratory compromise when they're delivered, if they're preterm. What's up?
Is county a high level NICU or no?
County hospital. County hospital used to be gangster level everything. After COVID, they didn't see enough population patients to retain their trauma certification or their pediatric level 1. Banner Desert also lost their pediatric level 1. They are currently provisional. There is one level 1 hospital in the state for peds right now, and it's PCH. Banner Desert is a level 2 provisional trauma hospital. Now, they will argue you till the cows come home, but you go to AZDHS and it says right there about their credentialing. So county has a high level NICU, but they're only a level 2 now, and they lost their adult level 1 credentialing. I think they're provisional now, but during COVID, all they saw were COVID patients. They didn't see enough patients to keep that up. Kind of wild, huh? One of the oldest hospitals in the state. Sexual assault. We chatted about this earlier. We need to make sure when we have sexual complaints from our patient to decide if it was consensual or non-consensual. And I talked about spidey senses or that gut feeling, like if you feel like this isn't adding up, it just wasn't right, separate the patient from any bystanders and contact law enforcement immediately. Most of these calls, they will go ahead and dispatch PD anyway and make sure it's code 4 before you enter. Because if you have a patient that was sexually assaulted, they want to make sure there's no violent parties left on scene that could potentially hurt any of us as first responders. So, sorry, my phone's still going off. We need to take really good care of our patients. We need to put them on the gurney, supportive care, get them to the hospital. Do not put their belongings in a plastic bag. I know we don't have paper bags on the ambulance, but if we put DNA remnants in a plastic bag, it deteriorates evidence in court. So my best practice is if you have somebody that came home and changed their clothes, just pick up their clothes and put them on the gurney and take them to the hospital and let a forensics team investigate when you get to the hospital. Don't stay on scene. Try to tell the patient not to shower, not to remove their clothing, because it retains more DNA type evidence. This is where I wish that we did more of like a crime scene class, because EMS, like a couple of my best friends are law enforcement, and they call EMS people, a little bit of bad words, but they call us evidence destroyers, because we cut through bullet holes, we cut through knife wounds, we cut clothes off, we destroy evidence while giving patient care. So I'm just saying be cognizant of that. Don't do any exams on these patients, take their word, transport them. They need a team that is certified in giving a rape kit to this patient and a rape assessment to be the first ones to examine this patient, okay? Sounds kind of weird, no plastic bags. Take the clothes with you to the hospital. Try not to destroy forensic evidence. If there's bodily fluids on this patient, don't touch them, transport them however you find them to try to keep evidence together. Either gender, any gender of patient can be sexually assaulted. Rape is a crime and it is a mandatory reportable offense, meaning we contact law enforcement in the agency in which the crime happened. On the assessment, try to give the patient some privacy. If you have the same gender of provider, that is the best, and give them an assessment with the least amount of people present, right? This is humiliating. And if there's a crime scene tape put up and there's neighbors coming out of the woodwork, try to cover up the patient and just get them in the back of the ambulance before you have any conversations, keep in mind everyone has a camera at their disposal. Hold up your cell phones. We all have these recording devices in our hands. Please make sure that we provide a level of comfort and security for these patients, cover them up, transport them to the ambulance, and give them some empathy. It doesn't mean do a full assessment. Some of these patients won't even want to talk to you, and that's okay too. Please make sure you ask to touch patients who have been sexually assaulted because it may trigger them, it may make them really upset. Explain everything that you're gonna do. Hey, I'm gonna put a blood pressure cuff on you. It's gonna squeeze your arm, just like a little kid. Because people who have gone through traumatic incidents, they need to have things thoroughly explained to them. And sometimes the lights are on and no one's home. You're talking to them and you're not getting through. That's okay. Just explain yourself. Have respect for your patient's feelings. Discourage the patient again that will do anything to destroy or contaminate evidence. And we want to document everything we see, heard, what the patient was wearing, their emotional state, all of it, because this is most likely, if you have a rape case, just be ready to go to court. It's gonna happen. Here's where things get a little bit tricky. Intimate partner violence. Some people think that if they're in a relationship or they're married, that any sexual act committed is consensual. It's not. So you could have a husband and wife or two partners, and they could say that I was sexually assaulted. We need to respect both parties involved, and it's not our job to be judge or jury to find out who is guilty, who's innocent, who was the aggressor. Try not, if you're transporting two people, to take them to the same hospital if there's sexual assault or violence. And again, contact law enforcement to let them sort all of this out. If you have a person with a foreign object, keep them calm, protect their dignity, and transport them. Do not let the patient walk, especially if the object is in the rectum. By the patient walking, your muscles contract and the object migrates further and further up. It's kind of a mess.
If we see a foreign object and we're concerned, like we can't move the patient, right?
Like they're impaled.
I wouldn't say that, but if there's too much of the object sticking out, right?
We don't take it out.
I see a dog, but I've had to break a leg to fit it in the ambulance before, so you know.
What?
Yeah, we had this guy on a motorcycle, and he was hit so hard his knee looked like a cactus. And I was in charge of holding it, and when we went to put him in the ambulance, his fucking ankle was like this on the doors. And I looked at the captain, I was like, what do you want me to do? And he was like, snap that shit. So he was like, okay, and I snapped the leg back.
Hard no.
But that's what I'm saying with this. Like, if it was
Just laying prone.
You could have adjusted him on the gurney.
Okay.
There's multiple things.
So-
hey man, the captain told me to do it.
Sometimes foreign objects are things like knives, like someone's been stabbed there, and that knife blade could be the thing holding that vessel together. If you pull that out, they bleed out, right? We don't also want to be causing any further damage. These obstructions, like this needs to be a nice moist environment when those things go in. If they stay in there over time, dryness occurs, like you can literally tear tissue out, right? So this is something that you leave in place if you see an object and you just take the patient to the hospital and let them surgically handle that. We don't want to be responsible for tearing out someone's insides by mistake, right? Kind of a yucky thing. Yeah, don't let them walk, put them on the gurney, and when you're doing this assessment, be very professional. Again, if you have to take a look at that genital opening, take a look at it for documentation purposes. Only one person needs to. It's not like a whole thing where, hey, you gotta come check this out, right? That's humiliating. We don't wanna do that. So we're just gonna conduct our thorough patient assessment and document how we found it. Again, remain non-judgmental. But if your spidey senses tell you, or your gut feeling says this is bad, listen to that feeling, right? Listen to that. If you think it's bad, you can always call PD and they can make that determination whether or not this was consensual or non-consensual. Right? Let them make that decision. One thing that you can do, this goes back to your question, Ben, is if you have a foreign object, it's transport the patient with their knees flexed together, kind of like a breech delivery like you were saying. They don't say elevate the pelvis. I would, just whatever the patient is comfortable, the position they are most comfortable in, I would just say I transported this patient in a position of comfort. The patient was most comfortable on their left side, on their right side, supine, right? Have you guys met Tim Glover?
Yeah.
He
The horse killer?
yeah, he did hit several reservation horses. He had a call, or maybe it was Matt Dillard, where a fire agency transported a patient prone, like face down on a backboard.
Is this the
That
guy
was
with the thing up his butt?
Yeah.
The mop room?
I don't know what it was. I know that it was an obstruction to where they transported the patient prone, and they got called on the carpet by their medical direction, because they said that was the patient's position of comfort. And you said prone position, you documented face down on the gurney, like how do you manage the airway? They were destroyed in court because they documented that they transported a patient prone, face down on the gurney. So you need to make sure that when you're documenting that it is appropriate. Do you know about this call?
Yeah, it was this guy was at Chipotle, Cafe Rio, one of those, and the guy had a broomstick up his butt, but it was a bunch of the broomsticks up his butt.
Yeah. Yeah.
Wait,
And
he
they-
was on a backboard? Was he combative?
No, they just, like, position of comfort, they documented that the patient was prone, that they put him face down on the gurney and transported him in a prone position.
Did
I would-
anything happen to that patient?
Huh? It was just taken
Why
to
did it go
court
to
because, they were trying to determine consensual versus non-consensual. I wasn't there.
Okay.
It did happen in Tempe. I don't know the logistics of it, but when it was called to court, the judges like, you transported a patient on their face who had already experienced trauma. How did you, or the lawyers like, how did you make sure to keep a airway on this patient? So like, they were torn up one side down the other on this call, like it was ridiculous. So that's why your documentation, again, is key, and these things are gonna go to court. So if your patient states that they're most comfortable laying on their stomach, document that. The patient's laying on their stomach en route to the hospital, with their head tilted to the side, their airway was intact, they were adequately breathing, patient was most comfortable, and requested to be transported like this. Our best way to transport a patient is either on their back or turned on one side or another, so that we can adequately secure them. The other thing that got called to court, or called to the attention of the court, is how do you secure a patient on a backboard who is face down, stomach down, right? Like, make sure their nose isn't on the hole, right? I mean, it's just documentation. Ultimately, I believe the family and the patient tried to sue the EMS agency because there was some complications, some big medical bills that happened, and when people have big medical bills, they look for a supplement or a settlement to see how they're gonna pay for these things. So it was pretty sad. But first responders, like, we all mean well, but we are oftentimes like the first target in an incident. Yeah, low hanging fruit. And a lot of us are tied to government agencies, because what do people in the general population think city agencies have?
Money.
Right? Like, they think that there's a settlement or a payout. So these cases and these patients are very sensitive subject matter. It's so important that you document, like, your career depends on it, because in this case it might. And that's why best practice, like, if you get a call for a foreign object like in someone, I would call for PD. I would also, they're the ones that should ensure that the scene is safe and that everything is going to be documented appropriately, and how evidence is going to be retained. So I think that a lot of us call PD a lot, and that's why, like, they laugh and call paramedics and EMS evidence destroyers. They also call us second responders, because PD is the first responder, because they're always clearing a scene. But ultimately, with these things, if we're gonna stand in front of a court, in front of a judge, we need to make sure to have our ducks in a row. Again, these things can go on for 7 years. Like, this person could have had massive complications from this removal surgery that they had, and they didn't like how you transported them, and the way you transported them made the object, again, work its way further up, causing more damage, right? You see how these things can always come back to EMS, how we handle patients. If we made them walk to the gurney, a couple of times it says, don't let them walk, because walking constricts muscles, which make objects migrate further up. So again, we could be potentially making these calls worse. So consider pain management of these patients. What would we give this person for pain?
Fentanyl,
Morphine.
morphine.
Why would you say fentanyl?
Definitely not.
Hey, that seems
Ketamine.
like it hurt.
No,
Huh?
definitely not ketamine.
Why? Why or why not?
I would use
Severe
ketamine.
pain?
Disassociate.
Why not ketamine?
Okay,
Well,
so
no,
let's
actually, we would not get ketamine.
Yeah, way harder.
so let's devil's advocate this. Micah, you
The
have
book does
a
say you can get-
24-year-old female in Scottsdale, and she's altered, and she appears to have been the victim of sexual assault. Do you want to treat her pain, or what do you want to check on this patient? She's altered.
She's altered.
She's altered. Who said respiratory rate?
Drive.
Okay, cool. What else?
I mean, your general ABCs and whatnot, and then try and figure out what happened
Yeah.
as much as possible.
Okay.
But
Yeah. So we want to get the story of why she's altered, Michaela.
I guess I take my answer back, because if I give her those drugs, but she was drugged by those drugs, they won't know the difference.
Okay.
Yeah,
Or
that's
those
great.
drugs could potentiate each other. Like if she was given a benzo, roofies, rohypnol qualifies as a benzo, and we give pain management, we could potentiate those drugs and potentially have an airway compromise. You're correct. Who here works in Tempe or Scottsdale? You work in Tempe. Come on down.
Like, get up?
Yeah. You look tired. You look like you need to come stand by me.
No, I need to go home.
Okay. Tell me a patient that you had that was drugged or altered, and you set the scene, and then you're gonna pick someone to treat your patient.
Like, set the scene? Like,
Yeah, so give me any female patient that you've had that was altered, and let's figure out why in Tempe or Scottsdale.
there's so many, it's kind of
Just pick one. Let's see if we can guess.
Beep, beep.
yeah,
Give the one you just told me.
well, that guy was on PCP and he got shot.
Oh, you told them now.
Okay, so
Oh.
PCP, like someone on PCP could pick up a gurney while being shot and they have no idea. I'm more
But
talking about.
they gave ketamine, we gave ketamine, and he tried to beat everybody's ass.
Yeah, that's probably not a good plan.
So,
Now you know now you know
now
what you
yeah,
did.
can't mix.
So what would you have done instead?
oh,
A lock?
This.
Hold on.
Probably just sedate him, but
Okay, how?
I mean,
We're not gonna RSI.
That's what I was like.
We can't just throw a Pomade at him.
no, I mean,
Ativan.
sedate somebody, like, not
How?
like
Ativan.
unconscious, knock them out, but I mean.
How, Ativan? If somebody's, okay, so if someone's altered, what do we need to check before we give them drugs?
Sugar.
Blood sugar.
Airway.
Blood pressure? Blood pressure.
Oh yeah.
Okay, Victoria, what'd you say that your blood pressure was normally?
In the 90s, solid.
90s over 60, so you have Victoria, she's altered, sorry. Her blood pressure is 90s over 60s, are you gonna give a drug to sedate them?
It depends on how wild she is.
Yeah.
If we're
Why
being
not?
honest.
If we're being honest?
I mean, if she's rowdy in the back of my truck, yeah, I'm gonna sedate her.
What do you have? What's another
Oh, I
option?
should stop saying
without-
Can we
sedate.
restrain them?
Restrain.
Restrain. I should
There
stop
you
saying
go. Okay,
sedate.
okay.
I should block everybody
Thank you.
else.
All right. Hey, you're the candy woman. You're the candy man, candy woman.
I mean, you didn't
Hey,
do that. I wasn't
She wants her patients to be quiet. I value that, but that's probably not the best treatment. So someone that's sexually assaulted could have drugs in their system. We all answered groupies earlier today, right? We all answered groupies on the quiz. If we give another drug, they potentiate each other, we could have an airway compromise, or if Victoria's already at 90/60, what's gonna happen to our blood pressure? It's gonna drop, right? Hypoxia, we're not getting perfusion. We have to have a map of what to circulate our brain. 65. So I want you guys to look at maps of 65 or greater when we're talking about patients. I don't want you to necessarily treat blood pressure, because our first sign of treatment for Victoria with her blood pressure of 90/60, how much? Probably for 500, there's a formula.
20 mLs per kilogram.
Come on, Grace. Grace, I want you to write the fluid resuscitation formula on the board. I want you to tell me a best guess of what Victoria weighs and how much you're gonna give her.
Oh, I suck at weights.
Hey, this is a skill.
I can tell you.
This is a paramedic skill.
140.
I'm gonna say she's on 30.
5.
It should like 10,
I believe.
20
It's
mLs.
20. It's 20 mLs per
I know, that's what I
kilo.
told her. I was like,
So
you're
what's your
wrong.
fluid bolus?
Yeah.
She's 130, she's guessing 130 pounds. So what is that in kilos?
Someone do the math.
60.
Well,
No,
it's
no,
like-
no, you're on your own. Shh, shh, shh. She yelled it.
She's 147.
Huh? She already said 130. She said 145.
I told you.
I said 130.
Why am I asking for this? Because this is what you guys are about to do.
Oh, Melissa, and she's like,
So we're gonna get fluid. Okay, hear me while she figures out fluid. Giving fluids over this 20 cc's per kilo only makes us feel better for an artificially inflated blood pressure. Please do not chase blood pressures with fluids ever. If we give too much fluid, we knock out their clotting cascade and we're breaking the blood bonds that cause clotting, like in traumatic incidents, okay? So if we have a hypotensive patient, we go to 20 cc's per kilo fluid bolus only, and then we just maintain that map of 65 or greater so we have perfusion. Do not chase blood pressures in altered or traumatic patients. So what's our fluid bolus?
Saline IV and preferably an 18 gauge and the AC or higher.
How are you gonna give 1200 mLs?
I'll probably give her a bag of 1,000 and then take out 50 mLs from the 250 bag.
I like it.
And then maybe great.
I like it. So would you piggyback it in, or would you do?
I think you
Yeah, I'd piggyback it in too. But then if you take fluid out of the bag, when you hang it, what do you have to do on the bag? But you mark it. You
Oh,
mark
yeah.
it that you
200.
only gave. Yep. Okay. Anytime you change the consistency of fluid, you have to label it. You all just did the station, the medication administration station. So you have to mark it. So yes, you're gonna hang fluids. So Victoria's altered. She's 90/40 BP. We want a map of 65, which she's right there. So 2/3 systolic, 1/3 diastolic is your formula for figuring out your map. That's the easiest way. And she's just fine. So we're gonna give fluids and we're gonna transport. If she's combative, we're gonna restrain her. But a lot of these patients are gonna be in pain. We wanna check their vital signs and ask if they had the potential to have been drugged, right? Because if they have drugs in their system, we don't wanna add any additional drugs into their system because rape patients are also gonna get a tox screening when they get to the hospital. So that's part of it. So they're gonna get blood and urine panels, tox screening to see what they come back for. Yes.
I mean, I guess the only thing we wouldn't know is the quantity of a drug, we just tell them what we gave, right?
What do you mean?
I gave this patient fentanyl, so when she pops for fentanyl, it's because I gave it to her.
Well, she's not gonna pop necessarily for fentanyl. What's she gonna pop for?
Opiates.
Opiates.
Opioids, right? What's roofies?
Benzos.
Benzo.
Oh my god, her last name is Betsy.
Aww. She just linked Benzies to benzo, silly. But yeah, no, so so look at what we gave and we can still justify that, right? But I wouldn't, if I suspect roofies, give her a sedative, right, or a benzo.
Would benzos not pop differently than opiates? Like would they
Yeah,
show
it's
under
a
the
different
same?
panel, so opioids, benzos, it'll say, there's other tox screenings that are super sensitive, it'll say cocaine, marijuana, GHB, like, it says individual, otherwise it'll say opioids, cannabis, benzos, you know, it'll say what she pops for, it just depends on what kind of screening that they run. All I'm saying is be really careful about giving medications to patients if you suspect drugs or alcohol on board for these patients.
To be involved already.
Yeah, because we don't want to potentiate the action and then bye-bye airway. The other thing that we take away with patients with gynecologic complaints is the ability for them to retell their story or give a full assessment if they become altered. So we kind of do a disservice and we expand that timeline for when they can get treatment. That needs to be done pretty quickly, so we want our patients to be as awake, alert, and oriented as possible. The only other thing in here is management, as far as patient goes. If there's bystanders, talk to bystanders. If there's parents that need to be contacted, please let the law enforcement or authorities contact them. Why would we not want to be the one to contact parents? We want to get permission to treat, right? But I would have a law enforcement agency be the person to make the phone call. Why?
Law enforcement probably stay with that child, we're gonna drop them off and leave.
Yeah, they'll stay with them for continuity of care. A lot of times when you call through law enforcement cell phones, they record conversations. But the other thing is you now gave them a point of contact of who to get follow-up from. One of the biggest things that I learned in EMS is stop using my cell phone to contact people's parents. Because you know what they now have? They have your number, they have a direct line to you. That's one of the biggest things in EMS. Like, we think that we're doing someone a service by calling them, block your number, make it private, whatever you have to do, but or use.
Still
Do any of
works.
you guys have ambulance or truck cell phones?
Yeah.
I mean, you can
Touch
try
phone.
those, but you also don't want parents calling back on that number trying to check.
Let them bug the next crew all day.
Yeah.
All day long. Yeah. So, that's basically it for this lecture. I'm gonna give you guys a quick break. We're gonna brush up on a couple of things, chat. We're gonna make sure everybody is good on all of this.